Hello and welcome to my channel. This is Pritesh Yadav and today we shall be understanding indigestion. So without wasting further time, let's get started. Firstly, with understanding a brief about indigestion. Better, indigestion is a non-specific term that encompasses a variety of upper and abdominal complaints including heartburn, regurgitation, dyspepsia, which is an upper abdominal discomfort or pain. These symptoms are overwhelming due to gastroesophageal reflux disease (GERD). The pathophysiology of GERD occurs as a consequence of the acid reflux into the esophagus from the stomach, gastric motor dysfunction or a visceral afferent hypersensitivity. A variety of situations promote GERD, that is increased in the gastric contents from a large meal, gastric stasis or acid hypersecretion. Physical factors from nausea vomiting can be increased by bending over. Increased pressure on the stomach from tight clothes, obesity, ascites, pregnancy and even loss of the lower esophageal tone from diseases such as scleroderma, smoking, anticholinergic drugs, calcium antagonists can also cause indigestion. Hiatal hernia also promotes acid flow into the esophagus. Now we shall understand the natural history of this here. Heartburn is reported once monthly by 40% of the patients and daily by 7% patients. Functional dyspepsia is defined as a dyspepsia of greater than 3 months without an organic cause. Functional dyspepsia is a cause of symptoms in 60% of the patients with dyspeptic syndrome. However, peptic ulcer disease from either Helicobacter pylori or an indigestion from the non-steroidal anti-inflammatory drugs NSAIDs is present in 50% of the patients. In most cases, the esophagus is not damaged, but 5% of the patients may develop esophageal ulcers and some form of strictures. 8 to 20% develop glandular epithelial metaplasia, also termed as a Barrett's esophagus, which can progress to an adenocarcinoma of the esophagus. Extraesophageal manifestations include asthma, laryngitis, chronic cough, aspiration pneumonitis, chronic bronchitis, sleep apnea, dental caries, halitosis and hiccups. Now evaluating a patient of dysphagia. The dysphagia, odynophagia, unexplained weight loss, recurrent vomiting can lead to dehydration, occult or bleeding. A palpable mass or an adenopathy are alarm signs that can demand a direct radiographic, endoscopic and a surgical evaluation. Patients without the alarming features are generally treated empirically. Individuals more than 45 years can be tested for the presence of H. pylori. Patients positive for the infections are treated to eradicate the organisms. Patients who fail to respond to H. pylori treatment or those who are more than 45 years and those with the alarming factors often require an upper GI endoscopy. Indigestion treatment. Weight reduction. Evaluation of the head of the bed. Avoidance of a large meal. Smoking, caffeine, alcohol, chocolates, fatty foods, citrus fruits and NSAIDs may prevent GERD. Antacids are widely used. Clinical trials often suggest that the proton pump inhibitors like omeprazole and pantoprazole are more effective than histamine receptor blockers like ranitidine, cimetidine. In patients with or without the esophageal erosions, H. pylori eradication regimens can be used. Motor stimulants like metoclopramide or erythromycin may be useful in a subset of patients with postprandial distress. Surgical techniques like the Nissen fundoplication Belsey's procedure work best in patients of young patients whose symptoms can be improved on proton pump inhibitors or who otherwise may require lifelong therapy. They can be used in rare patients who are refractory to medical management. Clinical trials have not been documented to be superior of one over the other. If you enjoyed this video, please consider liking and subscribing to my channel to bring such more videos for your understanding and improvement in your knowledge of medicine. Thank you very much.